Welcome to Dispatching Occupational Therapists, responding to the mental health needs of first responders, an Ontario Society of Occupational Therapists podcast. We invite you to hear from experienced occupational therapists and be inspired to work in this rewarding area of practice. This podcast is for informational purposes only. While some of the information may be generalized to other clients or situations, it is not intended to be used as clinical advice at any time. Any health professional listening to this podcast is required to use their clinical judgment, make their own decisions for best care for their clients. Furthermore, the information provided and/or opinions expressed by the members of this podcast are strictly applicable to the specific client and situation to which they are referring. The members of this podcast and OSOT waive all liabilities relating to listeners' use or distribution of this information for any purpose other than what it is intended for. This podcast discusses a select number of assessments and treatments, but by no means does it represent all of the clinical options that may be utilized with this population. For a comprehensive list, please refer to OSOT's reference guide, Occupational Therapy in Mental Health and Return to Work. Welcome, Colin. It is a pleasure to have you here at our First Responders and Occupational Therapy, Working Together to Make a Difference in Mental Health podcast. I'd like to start, Colin, by just having you introduce yourself and just tell us a little bit about who you are and your experience as an occupational therapist with first responders.
Thanks, Nancy. Thanks for having me. I appreciate it. Love the opportunity to talk about this really important topic. So my name is Colin Chan. I'm an occupational therapist with CBI Health, and I've been an OT for about 15 years now. And I would say it's interesting. I started off my career many moons ago, not really in the mental health arena, but over the last couple of years, I currently lead a team of OTs of about almost 100 OTs in Ontario in our psychological community program, working a lot with first responders. I would say about 50% or more of our caseload currently across the province, about 1,000 or so files that we have are first responders, including police, fire, EMS, corrections, and dispatch. So my last couple years in my career, I've been devoted almost exclusively to working with first responders in trauma.
Wonderful, Colin. Well, it's a pleasure to have you here to be able to speak to occupational therapists, to let them know a bit about what are the challenges and opportunities in working with first responders. I'm going to start kind of my question with, tell us a little bit more about your program in terms of the theories and the process for assisting first responders at CBI.
Sure. It was interesting. At the inception, this program really started out of need. So to your question, what are some of the theories? We do incorporate a lot of behavioral activation, exposure therapy, CBT, CPT, DBT, those kinds of interventions from a mental health standpoint. But really, this is such a unique space. First responders, in our experience, do not want to work with clinicians that do not understand the first responder culture or the world within which they live and they work. It's a very niche space and a very unique area, and I think it's really important that any OT that gets into this space truly has a good understanding of what their jobs and their worlds entail, because if you can't speak their language, you don't understand the things that they talk about in terms of jargon or just the organizational or situational or personal barriers that they encounter, it's hard to really build that rapport and to make that connection. And long story short, I think the most important factor in terms of approaches for this kind of clientele is having a therapist that has the ability to connect with their first responder client. If you cannot engage and build a therapeutic alliance, which is, in my opinion, 80%, maybe more of the issue, then all of the clinical interventions aren't going to land. So it's really important that you have someone that's interested and passionate about this space in terms terms of trauma and in particular first responding. And then from there, everything just kind of fits. But we spend a lot of time training our folks. So in our specific program, all of our recruitment, hiring, and then onboarding, training, mentorship is built exclusively around trauma and first responders. The one thing that you'll find as an occupational therapist is coming out of school and even out there, and once you start your careers, OTs do everything, right? OTs do a little bit of everything. We're trained as generalists, and most OTs, whether you work for a private practice organization or you have your own business, we tend to do everything from ergonomics to FAEs to PDAs to concussions to mental health, right? And because we dabble in many different clinical spaces, I would argue that you don't necessarily become an expert necessarily in one particular space. But with first responders, this is one area that I think it's really important to have some additional training and expertise in, which I think helps to set you apart, which really gives you some buy-in from your clients.
So Colin, if you're speaking to an occupational therapist, as this podcast is, where would they go to get that specific education or understanding of the first responder community? I'm sure you have your own program, but a therapist on their own, where would they get the best information for that?
It's hard. I think, in our specific program, we spend a lot of time training internally because we work with such a large first responder population. We actually invite many graduates or clients who have completed our program successfully and return to work, return to life, come back and they'll speak to our clinicians, our new hires and our students to speak to their lived experience. But externally, OSOT, as you know, Nancy, has some tremendous resources, including this podcast. We did a workshop at last year's conference as well, speaking specifically to first responders and mental health. There was a 2-part series last year. So there's things like that available, but in terms of first responders and even working with military or veterans, I would recommend cognitive processing therapy as a course and prolonged exposure therapy. I would say those are 2 interventions that strongly guide our interventions as OTs in this space. And a lot of the training and the courses do speak specifically to this population.
Great. So Colin, once you've built that therapeutic rapport, that relationship with that first responder, and you're working through using CPT or prolonged exposure, what are some of the unique challenges that you have experienced in working with first responders that you'd like to tell our audience about?
Probably there are multiple challenges, but probably the one that stands out to me with this population is the employer-employee dynamic. There's always return to work issues and the same kinds of challenges with any return to work plan with any employer in any industry, but specifically with this group, there's been a lot in the media. Most people will be aware of suicides among the first responder population. And there's a lot, because this is a hot topic, there's a lot of conversation. We've had multiple meetings with multiple regions and municipalities and different services around how can they as employers better support the mental health and wellness of their members, be it police, fire, EMS, or what have you. Mental health in the workplace in this group is so strong. And although it's improving, there is increased awareness for sure. There's increased understanding of how to support each other and how to identify mental health in the workplace. I think that it's still existent, like the whole locker room culture. And because this is a profession and a world where it's really important that you trust the people, the men and women beside you in terms of your own safety. Like you lean on each other, you rely on each other to have each other's back. When there's a chink in the armor, so to speak, and you get the sense that your colleague isn't fully equipped that day or that month and is struggling with their mental health, and you may lack some trust in their abilities to respond or to react in the right way, it really does impact their relationships in the workplace and also their reputation and their opportunities for promotions and things like that. And because it does impact their jobs, many first responders are not willing to come forward and to speak openly about it and to seek support. They're not a health-seeking group of individuals in general. So by the time they do start receiving treatment, or they do come forward, or a claim is approved, oftentimes they're a lot further down or below their baseline than we'd like to get them. So in terms of early intervention, sometimes that could be an issue with this group, just because of the stigma that comes with it and their lack of willingness to seek help when they need it.
So as an occupational therapist, and I'm working with a first responder, and I'm seeing that chink in the armor, or that stigma exists within the relationship between that first responder and whoever they're working with, what strategies can the occupational therapist provide to be able to break down some of those stigmas and barriers?
I think as OTs, again, like I mentioned, we do so many different things, and part of it is as we know, as a profession, we advocate, right? We're client-centered, and we speak on behalf of the voiceless and our clients, but also being in that ideal middle ground where you have a connection point with your client, and you have a level of trust, and they know that you're there for them, for their best interests. But then you also are standing in a space where you have the opportunity to speak with a credible and valid voice to the employer. And I think just marrying those two things, because there's such a large gap between them. I was talking to one police agency a while back, and they mentioned that sometimes they have the best intentions at heart and they truly want to help, but they had, I think, 500 active members or sworn officers on duty at any given day. And on any given day, they had 250 members that were off work or on modified duties. And you think about half of your workforce is on accommodations or off work. How do you run an operation, right? How do you ensure that the public and the communities are safe and that you can service it adequately? It's almost impossible for them to give the requested or grant the requested modified position. Like, you can't give everybody what they want because there's only so many positions available, right? So I think as an OT, understanding what your clients' needs are, understanding their barriers to return to work, both from a mental health standpoint in terms of their triggers or their symptoms and kind of what their clinical issues are, but also recognizing from a client standpoint what their pragmatic barriers are that we can help to problem solve around, that aren't necessarily symptom-based, but are practical in terms of communication or assertiveness or organization, things like that. So recognizing the client barriers, but then also recognizing the barriers on the employer side and having frank and open conversations with both parties to say, this is what we're trying to meet, and finding a compromise that works on both sides. And I think having a therapist that's outside of the organization that is essentially neutral and unbiased to come up with terms that work with both sides. And I think just being in that space as an OT and having a good understanding of what is possible within the workplace. And I think this is where it goes back to your question, like what's important for OTs to know working with this population is that if you understand the job and the different divisions and the different organizational structures within these institutions, you can better recommend accommodations and modified positions. Sometimes if you don't understand and you make a recommendation to a first responder or to the organization, they're like, that is not feasible. And once you throw that out there, it really reflects your lack of kind of understanding of the work that they do, and then you kind of lose some credibility. So I think getting some training and understand and working with first responders to understand what the possibilities are in terms of accommodations, that goes a long way in bridging that gap.
Great. And I think that what you've talked about is one kind of looking at the system, right? Mm-hmm. In terms of what can the system offer to the employee that you are working with from an accommodation perspective, and being realistic and not going in as a bright-eyed clinical therapist who says they need to have, breaks every exactly 30 minutes when they're out on the road and they're needing to respond and they're in certain situations. that there is no option to be able to take a break. It is really more working on how they manage that heightened requirement of being, on during that time, and then how do they manage that afterwards in their downtime, right?
Exactly.
How do they communicate their needs to their colleague, to the ranking officer, whoever, the chief that they might be working with, so that they can express their need in a way that works within that setting. And I've worked with a lot of people in the first responder groups. We're in kind of a paramilitary kind of environment where the management is used to telling people what to do versus being able to work more collaboratively on that approach, and being able to communicate in a very respectful but assertive way is really a key skill set that I've seen many first responders needing to work on. So do you have an example in terms of one of the situations where when we look at accommodations that have worked really well with any one group of first responders, or would you say that it's all very individualized?
Definitely very individualized. I think it's important that you apply some critical and clinical reasoning with every plan that you put forward. And it's really important that your plan, when it comes to accommodations and graduated return, is clinical, and there is some rationale behind it. So just to give you a specific example, there was one region that we worked with, and at the time, again, this was a couple of years ago, before they really started to understand that OTs could help to facilitate the process, that their return to work policy, whether you were off work for 1 year on a parental leave, or whether you were off work for 10 years with PTSD, with a psychological injury, the return to work plan on paper was the same. You get 3 days of reorientation and training, and you're expected to be back full duties, full hours as a paramedic, no questions asked. And there was no flexing and no options to change that. And you think about that, and anyone that looks at that knows that doesn't make any sense, but that was the policy, and no wonder nobody would even bother trying to come back after a mental stress injury absence. And those people that did try would ultimately fail, right? So it wasn't a good policy. So after doing some education in terms of helping them to understand what they could do to accommodate and to offer some flexibility within that, we went from 3 days to essentially blending treatment and return to work at the same time. So it was important to distinguish between access to the workplace. So this was like an EMS job, a paramedic job. We were able to get access to resources and equipment and locations within the workplace at headquarters that would allow for treatment to prepare them for the return to work. So we were able to get access to the ambulance bay, off-duty ambulances. We were able to to do some driving training with an ambulance, with a peer support. We were able to get access to a simulation lab to do some exposure therapy with blood and bodies and sirens. So getting access alone to the workplace for treatment purposes to essentially prepare them. For us, it was clinical. It was a lot of exposure therapy, but essentially it was not throwing them back into the fire, but easing them in slowly. And it took a couple of weeks, but eventually we were able to get the paramedic clients a ride as a third in the ambulance. We were able to get access to a radio so we could prepare for different calls and to the radio, etc. And eventually we were able to get them transitioned to different modified hours and being an active duty paramedic, but they would assign a third paramedic so that they could have some support just in case they needed to step back or they couldn't manage something. So it was a very gradual return, but in the end, the client was able to return to full or pre-injury duties, pre-injury hours, was able to sustain that long term. So if you think about the return on investment, yes, it took longer. It wasn't 3 days, obviously, but the employer at the end was happy because they actually got the client to return to work and to stay at work. And sustainable return to work is the name of the game. And it just took some prodding and some education to get employers to understand that and to buy into it.
And I think there's a few things there, Colin. Great. I love that story or that approach, because what I've found that many occupational therapists might go in with more of a cookie cutter approach, or might hear that this is the employer's policy and so you can't do this. And so one, working collaboratively with the employer to educate, to understand why you're recommending something, to have some good clinical reasoning behind it, and to be able to look at the outcome as sustainable versus quick. And I think those are really important principles when we start to look at any return to work, but especially with first responders, that going in with 3 days after being off for 10 years is pretty unrealistic. But as an occupational therapist, we have the opportunity to be able to educate on why a different approach is worth trying and the outcomes that can be achieved from a sustainability perspective. So making sure we're not necessarily, when we're talking to an organization and they say, no, 3 weeks return to work and it's 2, 4, 6, 8, and that's how they come back. That's what we're ready for. That's what our policy says. That an occupational therapist can provide some really good education to the employer about why that's different for someone who is coming back after a psychological injury. So
yeah, exactly. And just I think having that clinical reasoning, it's so critical to customize your plan and to advocate for that, because specifically, I mean, in general, yes, for mental health, but specifically for PTSD, you could have 10 first responders attend the same traumatic event, and each of them, say, gets a diagnosis of PTSD, but what it means to that individual first responder is so different. So the triggers and the intrusive symptoms and the flashbacks that they get, and subsequently the type of treatment that they get, all will be different, right? So even though they all attended the same call, right, their treatment and the returns work plan will be different because of what that trauma means to them individually. And I think as an OT, being client-centered, and it always goes back to being client-centered, is just recognizing the specific nuances in terms of what is meaningful to your client, because trauma is not about the objective facts of the event. It's about what it meant to that person. And sometimes the employers don't understand that, right? Because they see the event and they think of that as the precipitating cause of everything. And that is the triggering event for sure, but it's ultimately PTSD is an individual diagnosis based on how it resonates and relates to that person.
Absolutely. And so, yeah, occupational therapists are so well suited to be able to work in this field, to be able to help from the trauma perspective and the mental health perspective. I just think about, the way that we talk about depression, anxiety, post-traumatic stress, that it's a broad, these are the symptoms. And I love that you brought it back to, this is the individual, right? And so it's how that individual is experiencing that, is perceiving that, and what strategies will help that individual is not a cookie cutter approach. It's individualized and client-centered. So love that. Mm-hmm. I think you reinforce the skills of an occupational therapist is to really be able to, and I'm going to put this in kind of business terms, really, to be a salesperson, right? To be able to look at what's in it for that other profession, what's in it for that individual, that first responder, and how do we ensure that we're adding meaning to that process. And I think that's one of the things that we can all kind of work on a little bit more, is to really find that niche, find that gap, and demonstrate our skills. So that's wonderful.
Yeah, I love that analogy as a salesperson, because you could be the smartest and most talented and skilled clinician and do the best work with your clients, but unless you have built a good relationship with other stakeholders, such as a psychologist who often holds the cards for these kinds of cases, you could be a great OT with no clients, right? So just to give yourself that opportunity to work with these clients, sometimes you have to market yourself and find ways to insert yourself. And those are not necessarily clinical skills, but I would argue that a lot of the skills that we use in sales or self-marketing or promotion are the same skills that we use to build rapport with clients in terms of empathy and active listening and those kinds of things.
And I think I love that. And I'm going to kind of wrap it up soon because I know you're a busy guy. But I think that that's one thing occupational therapists need to hear, that we are, amazing clinicians, but if nobody knows about it, right, and nobody knows what we can offer, then the louder, the better marketer, whatever, gets the pie, right?
Yeah.
And as occupational therapists, we are overall a humble profession. I think that it's just common sense what we do. Doesn't everybody know all of these things? And I think what I've loved about your approach, Colin, is you're getting out there, you're speaking to the first responder community, to those organizations, to WSIB, to psychologists, to be able to say there is a better way and we can offer some support to be able to make this happen. And so thank you, Colin, for continuing to promote occupational therapy in this realm and to continue to be involved in those activities that do that. Is there anything, Colin, that you would like to share with occupational therapists going into this space, that either words of advice or resources that they might want to investigate further?
I want to thank you for the opportunity, Nancy. I think this podcast is amazing, and I think OSOT's doing some great things in terms of helping OTs to better understand this very niche space. Trauma in general, but specifically first responders, I think is something that needs to be highlighted as an area that OTs can and should work in. And I guess the takeaway for me for OTs would be that never underestimate yourselves as individuals, but as a profession. To your point, Nancy, I think that there's so much that we can offer. And I think if you don't value yourself and you don't believe in the power that you have as an OT in any space, then no one else is going to believe it. So we have to be our own loudest voice if we're going to be making a difference. But in terms of resources, I think something like this podcast, like I said, OSOT has some great resources, but definitely look up just different workshops and seminars around exposure therapy, and I think CBT is helpful in this for this population as well. And I'm a big advocate that yes, you can take a 3-day course, you can take a 10-week intensive course, but I think all these other little smaller courses as well have lots of value. And I think as an OT, you can never learn enough. And you may have taken 10 CBD courses, but every single time I take one, I learn something new, just in terms of how you frame it, how you say certain things. And I think the better you can conceptualize in your mind and understand something, the better you are able to articulate it to a client or to a stakeholder when you're speaking about these things. And I think it's ultimately, yes, it's about what you know, but more importantly, it's about how it lands with your listener. And in this case, it's your client. So I think just taking multiple courses so that you can refine your education and your pitch, that's probably going to serve you well.
Wonderful. Well, thank you so much, Colin, for your time. Glad that we could grab this time from you. And it's amazing to kind of hear, I know probably less than a year, you had said that you had about 40 therapists, and now you're talking about 100 therapists doing this work, and that your expansion of this program is amazing. And so congratulations on that work, and keep doing the great stuff that you're doing. And thank you so much for being here.
Thank you so much, Nancy. Appreciate it.
Thank you for listening to Dispatching Occupational Therapists, responding to the mental health needs of first responders, an Ontario Society of Occupational Therapists podcast. This podcast was produced by OSOT's Task Force on Mental Health and Return to Work. Don't forget to subscribe and leave a review. Make sure to follow OSOT on Facebook, Twitter, and LinkedIn to stay in the know about all things OT in Ontario. Links will be included in the description. Check out the episode description for any resources we mentioned throughout this interview. Until next time, thanks for listening.